Dear colleagues, dear President, I would like to thank Professor Kotsis for the kind invitation to be in this panel and uh, generally the committee that organized this excellent satellite symposium, which is now with a long history as well. um, the the topic I'm going to discuss with you is how to treat a patient with chronic kidney disease and atrial fibrillation. Actually, it is a very difficult, gray, and foggy um, topic because we don't have it, could be the most difficult answer that you have to give to this patient, how to treat them, especially on the topic of antiplatelet and anticoagulant that you need to use for this patient. And you should use on these patients because all of them, they are with a high um, chance to have a stroke, but at the same time have the chance to have um, a, a bleeding that it could be disaster for these patients. Discussing for the two topics, which is the atrial fibrillation. I will start with the atrial fibrillation, and this is supraventricular tachycardia and tachyarrhythmia that could be we could very usually seen in these patients, and we have a high incidence for atrial fibrillation as we are going on with the aging of this patient. And if we discuss for chronic disease of kidney disease, it's a multiplier for the incidence of atrial fibrillation in these patients. And we have to have in our mind that there is a definition of atrial fibrillation, but we could have two um, the symptomatic and the asymptomatic atrial fibrillation, but both of them, they are still be dangerous for all of our patients. And the symptomatic normally it's the feeling of palpitation, dyspnea, or fatigue. All of them, they have that. And some of them, when they could be hemodynamical unstable at the same time, or some of them, they could have comorbidities as heart failure because of hypertension or because of ischemic heart disease, and could be very dramatic at the end, even with the cardiogenic shock of some of them patients. The global prevalence of atrial fibrillation is very high, and as I told you in the beginning, as the people and they're aging, then the numbers of people that are having atrial fibrillation, they will be higher and higher, and the problem will be higher, and we have to discuss with the problem and find a solution. And the solution will be how to treat these patients. As you can see, with the aging of the population, if we see in the future, we have a very high percentage of patients with atrial fibrillation, and this is a very, very difficult task because most of the things that you are seeing in this slide are with the atrial fibrillation multiplier. You could have more deaths, and the excess of mortality could be with the comorbidities, the stroke and the heart failure. You could have stroke, yeah, left ventricular dysfunction, which is the heart failure we're discussing, vascular dementia, depression, and generally, which is more important, is the quality of life. Most of the patients with the atrial fibrillation are getting a lot of troubles, and their life is not as normal as we think that it will be, as because of the atrial fibrillation. Um, in this slide, you could see the atrial fibrillation in the center and how it's correlated with a lot of comorbidities. And the center of that is the aging, genetic, the male sex, and what we will discuss, the chronic kidney disease. There are a lot of scores that we're trying to have in order to find out if you have atrial fibrillation and to assess the risk to having atrial fibrillation. And this is very important when we're having these patients with chronic kidney disease. And this is something that we should do in the beginning of the first consultation with these patients in order to find out if they have the probability to have atrial fibrillation, or if they have the atrial fibrillation indeed. Chronic kidney disease and atrial fibrillation are both risk factors for bleeding and stroke and high mortality. This is what is doing the difficulty for the two factors. The prevalence of atrial fibrillation in this kind of patients, I mean, kidney disease in the general population is the first two bars, but we were discussing for kidney patients, we have multiply times that they could have atrial fibrillation, and this risk of kidney disease have a high relative risk for stroke, and you could see that in different subgroups for these kind of patients. And at the same time, we have higher rates of mortality for these patients. And why is happening this? Could be happening because of the activation of the renin-angiotensin system, and this is having inflammation, atrial enlargement, diastolic dysfunction, myocardial fibrosis, and this could be the reason of the development of atrial fibrillation. And this is very important because both of them, atrial fibrillation and chronic disease, then they are strongly related with ischemic stroke, bleeding, and mortality. We don't know if there is interaction between the chronic disease and atrial fibrillation in multiplying the cardiovascular risk, but if we have patients with already steady arterial disease, then in this kind of patients, we have interaction. From clinical point of view, this is very important to know for these patients because, as I already told, it is increasing the bleeding and mortality, and we have to know who of them they have both of these entities, atrial fibrillation and chronic disease. So the question for this is when and which of the anticoagulants should use for these patients, and if we are from one point giving the right anticoagulant therapy, but at the same time we are giving high chances for bleeding and increasing mortality for these patients. In our mind, we have first the vitamin K anticoagulant therapy, but now all this last nearly 20 years, we have all this what we call NOACs, and we don't know if we could use them more because we don't have a lot of information. This is the the state where we are at the moment. Atrial fibrillation and chronic kidney disease, it's a bad combination, and you could see that in a lot of papers, and especially in our everyday try to give and to treat these patients. And the other is, and we discussed that a research paper just in this April came out, the 2022, which saying it is a deadly combination to have a chronic kidney disease. There was from Utrecht a very big registry and study that give us a lot of information about the combination of atrial fibrillation and chronic kidney disease. And this is giving us that even the stroke, even bleeding and mortality, they are higher when we have both atrial fibrillation and kidney disease. And this is what we have in our mind, but we have the data to give that. The same is if we use the CHA2DS2 score. Again, we have the chronic kidney disease with atrial fibrillation be higher bleeding, stroke, and mortality. And this is giving us that the population that we're discussing is very difficult to manage. And this you could see in this slide, that these patients, if you have the Kaplan-Meier survival curve, they are most difficult, and they have a higher risk. So we have to give them the best, at least what it is at these days, the best opportunity to survive, but it will be even though difficult for that. The information that we are having are not very much. This is one study, the renal AF study, about using in hemodialysis patients the apixaban versus warfarin. It was stopped early because of difficulties that they have in their enrollment, but seems to be safe to use the low dose of apixaban, but it's not recommended. You just have one reasonable drug to use, but you need to be very skeptic on giving apixaban in this kind of patients. When we have to, what we have to do, it's important to have information what we are doing. And this is came out a year ago, one very big questionnaire that about the management of atrial fibrillation in chronic kidney disease, asking 300, more than 300 physicians who are nephrologists and cardiologists mostly, and we have a lot of information on that. What is important is that what we there is not in use is the multidisciplinary team. We don't have that in the whole Europe that we, and this is important that we should discuss that, and we should organize the multidisciplinary, the heart team that we are discussing, how the cardiologists discussing with the cardiosurgeons, has to be something that it should be in all the hospitals, and this is for the good of our patients. The second is that the routine assessment for renal function is not in a good state, and especially from the point of general physicians and cardiologists. So we need to have in our mind that we should assess the renal function before having the decisions of what we are giving to these patients. And the other is that we need to use different scores for assessing these patients. The other thing is that a lot of people, especially in this time, the nephrologists, they are not giving a lot of strength in trying to find out if these patients have an atrial fibrillation. So we should have in our mind that we have to identify these patients, and there are a lot of things that we could do. It's the information that having from the patients, but we have telemetry, we have Holter monitoring, and we could use them to find out who's of these patients. The information from this questionnaire, it was very important. If there is for the stroke prevention strategies, differentiate uh, the chronic kidney disease, and it's not giving this information. I mean, they are not changing their strategy because of the chronic kidney disease. This is the questions and the answers from the questions that we give them. And we have one very important information about the VK and the new drugs, and the cardiologists are more relevant to use the new drugs. The nephrologists are not so keen on that, and this means that we have to discuss that and to increase our experience and to use them when they are needed. Just in the end of the discussion, in my presentation, what we need to have in our mind that these patients have to be treated very well according to the guidelines that we have. And what are the goals? The goals are the anticoagulation in order to avoid stroke, the better symptom control, which is very important. I discussed in the beginning about the quality of life, and then the comorbidities and the cardiovascular risk management that we should have for all these patients. And if we do that in a good way, then we have a better expectation for our patient. And we have a lot of scores that we could use, which is the JATVASC, the Hasbled, and the same TTR scores that we could use for these patients. And they are giving us who we need to treat. And then this is very complicated, seems to be very complicated, but it's not. According to the JATVASC, we could have our patient, stratify them to the risk that they have, and use according to the thromboembolic risk vs the bleeding risk, use what it's called the anticoagulant or the new anticoagulants or the classic VK drugs that we have. And this is how we could use our in Greece we have the three of them. In Europe we have also edoxaban, and we could be very we have to have in our mind the renal function for these patients in order to have the dose of the new drugs. This is not coming for the dabigatran, but normally we are using the low dose for a dabigatran in these patients. And this is the last two slides that I'm using, which is we need to control and modify the risk factor for these patients, and we need to use for these patients after individualizing our information for every patient, the new drugs, and we should be very cautious about the renal impairment or the severe renal impairment, which is not modifiable, but we should have in our mind when we are having what we have to do and which of the drugs that we should use. The same is coming for the antiarrhythmic drug, and the information that we are having is that we should not change our policy for these patients according to the chronic to the chronic kidney disease, but we should do the same thing for these patients. I mean, use the same strategy for patients with atrial fibrillation. And we must have in our mind that in some of these patients, we could use what is the new electrophysiology, the ablation strategy for these patients. We could be very useful for this kind of patients that we have. Most of the drugs that we could use are the beta blockers and other antiarrhythmic, which would be in stage use them first the beta blockers and then the other drugs, antiarrhythmic drugs, according to the renal function of these patients. Summarizing, I could say that they are very difficult patients. We don't have very straight and clear guidelines, but we have the opportunity to individualize, and we should be the doctors that are having the time with their patients, having the final decision after reviewing all the history of the patients, as well as with the parameters from this kind of patients, because they are in a strong risk of mortality, stroke, and having a very bad quality of life. Thank you.